Good day, all of Section 5. I hope this video wrap up finds you all doing well. So again, I'm going to try to make this brief. I'm going to continue to shoot for that 8 to 10 minute sweet spot so as not to waste your time. I appreciate everybody tuning into this. We had a good week. There were some really good discussions. We're going to review some of that stuff, and we're going to also do kind of a quick once over. There's a lot of material this week, a lot of topics, and so we won't be able to cover all of it, obviously, but hopefully kind of hit the high points. The Minkin presentation, man, was that all encompassing or what? It's a great reference. We don't have nearly the time to talk about everything, even within the threads. But I would highly recommend that you tuck that one away and use it, because some of these people are gonna cross your path. Myositis ossificans, osteitis pubis, those are not common things, but they're certainly going to happen in your clinic. Lord knows I've seen a fair share of mine in my day, and always like, wait a second, now what is that? So having that PDF is a great reference. The greater trochanteric pain syndrome. Just want to let you guys know that I posted in Dropbox a presentation that Bill Cook Bill Cook is another section leader. He and I gave a lower extremity talk for a private practice group, and one of the topics was greater trochanteric pain syndrome, and we both believe that it's probably more of this than any kind of hip bursitis. And so I posted in week 3 the presentation that we gave. So check it out when you have some time, or download it and check it out later when you're not in the belly of the beast, so to speak. But I do think it's well worth your time, and I think it might help differentiate between that concept of bursitis and what is it really bursitis, that whole concept. I posted an article too in Charlie, I believe, that kind of disproves that whole concept of bursitis, and it really is just kind of a garbage term. Yazbek, a quote that I thought was really interesting. Gluteus medius and maximus, iliopsoas weakness can contribute to increased anterior hip forces. Keep that in mind when training these people. Hip extension, gluteus maximus, gluteus medius minimus, all of those are really important in driving home that settling in of the hip socket. This article is not rooted in literature. Some of you all commented about, some of the literature we have on this is not great. I would agree. It's an impairment-based approach. There's limited evidence, but it's really all we have. And it certainly beats slapping an E-stim unit on them or putting on ultrasound. It's very functional in its approach. It emphasizes impairments, and you have kind of this theoretical construct in which you try to base your approach. Lewis and Sauerman, I'm not a huge Shirley Sauerman guy. I gotta admit, her research, the articles that she's published, they seem fairly tedious as far as getting patient compliance, and they feel fairly long-standing in that they have to comply for a significant amount of time. So her stuff is I've not always been able to embrace it because I don't always think it's very clinically applicable. But I think the article raises some really good points. I like the quote, 74% of all labral tears are not associated with any trauma. I think that's really important to understand, that people have labral tears who don't need to be treated. And so then you ask yourself, well, what is it that we're doing for the other 26% who have traumatic tears, maybe more pain, and why that is. I also posted an article about those who don't do well with surgery and what that would look like. Please check that out. That was by a Salad, I believe it was. It's a really good one, I think, to have for those people who are wondering what's happening. Again, Sauerman, they talked about posterior buttock pain being posterior labral, anterior hip pain being more anterior. And that's really fundamental kind of stuff. But just those basic things helps kind of hone you in. Higher stresses give us one of the contributors to labral tears, obviously, high stress activities. So be thinking about that with any kind of soccer, plant basketball, these plant karate, any kind of martial arts. And our goal, and she said, we're trying to correct these anterior hip forces. We do the best that we can. It's the same thing as what Yazbek said. I ran out of space here, but the athletic pubalgia, that was that too is along those same lines. Very difficult to diagnose, really an exclusion kind of diagnoses. But I have had people who have responded well to soft tissue work through the psoas, iliacus, hip joint mobilization, core training, weight bearing, hip strengthening that do fairly well, and may have these tears and may not. And if they don't get better under conservative management, that's obviously where you want to go. And as well as the fact that in that article, in that Kachingwi article, they talked about I think he threw out the 80%. I had this discussion in a number of different groups, the 80% at 4 weeks. Now, I really think that's fairly arbitrary and should not be used as a guiding principle. Again, that article, similar to the Asbeck article, were very much clinical commentaries. It's really all we have. In that article, too, we just don't see enough of these people to warrant huge studies that can be funded because they just don't make up a huge population. But we do still have to use sound clinical reasoning and judgment. We have to use what we have to try to get these people as better as quickly as possible and try that conservative management approach, because surgery is not the answer for a good chunk of these people. So notable comments this week. So I really liked Ken's vomit comment. Thought that was really good. And he's promised, he's off at a weekend intensive, he's promised to post vomit, meaning victim of medical imaging technology. He's promised, this is a handout that his clinic gives out, and he's promised to post it. Ken, I look forward to you posting it because I am, like Jess, very curious to see this. Stephanie, Justin, and Corey talked about the hip stabilization and the importance of that with these diagnoses. You know, if you have an FAI or if you have a labral tear, we really want to make that hip, all those muscles contracting together, firing together. And there was a talk about, you know, kind of the rotator cuff, if you will, for the hip. And I think those are really sound, again, principles that don't have a lot of strong evidence to back them up. And in theory, they make sense. And certainly, if that's what our guiding principles can tell us, we know that weight bearing is critical. We know that with that co-contraction, we know that this can be really important, and that concept of hip stabilization, I think, is very solid. Travis and Alicia, when we talked about this, is 80% in 4 weeks of athletic pubalgia. I thought they had some good back and forth about that topic, and, you know, basically they both agreed that was too restrictive. Alicia had a really nice chart breakdown of FAI versus labral tear that I would highly recommend in Alpha that you check out, because it does a nice job of just giving you kind of the entire picture. So nice work, Alicia. Matt commented in Delta that tests for labral pathology really were ruling out but not in. You know, most of these tests have some decent sensitivity to them, but the specificity on this stuff isn't really great. So you really don't know what you're treating. And again, these become diagnosis of exclusion more than anything else. But good work, some good comments, man. I will just stop here and pause and just say, Charlie, man, I mean, you guys had some really good banter. If you want to look, if anybody else in other groups want to know what we're really looking for, it's that really great dialogue, people engaging, getting their posts in Wednesday, engaging Thursday and Friday, really offering up some good information and some great exchange of information too. I was really impressed with that group's work. So anterior lateral knee pain and knee OA is our next topic. We're also going to have another round of fellow case studies, so feel free to check those out. We're going to be switching up groups. We'll have completed 2 weeks. We're going to switch up. I'll be sending those out along with the weekend wrap-up. And again, everybody seems to be getting the nesting. I would challenge Group Bravo to check out either any of the Alpha, Charlie, or Delta. Everybody else seems to be doing a nice job of nesting the one topic and then following within that original thread. And so if you could try to do that, that would be outstanding. Otherwise, you guys all have a great week, and we'll see you next week. Bye-bye.